Next, I would be presenting on current scenario and management of ROP, a tertiary care perspective. So, India is currently has the highest total number of preterm birth, which is estimated at 30 lakhs, and it accounts for over 20% of all the preterm births worldwide. This is a recent report from Lancet. So, coming to the preterm births in Bihar, so it accounts for nearly 16% of all the birth that is happening in Bihar, and the same percentage also contribute to the low birth weight. So we can imagine the burden of preterm birth and low birth weight in Bihar alone. So, how is ROP as a problem statement for all of us? So, at least 5,000 preterm infants will require ROP treatment every year, and 15% of all the patients who are admitted to the special newborn care units will need screening, and 15% of them will develop sight-threatening ROP. So, all these 15% will need urgent laser treatment by the trained ophthalmologist. So we had a CAP study done among the pediatrician regarding ROP. So we had a set of questions, and when we asked about the screening criteria, every 33 of the pediatrician, they followed the standard guidelines. They followed the criteria of gestational age in all the patients, and the birth weight in nearly 75% of the patients, and they took into account other risk factors in approximately two-thirds of the patients. So, regarding the timing of the screening, they had the infant got screened at around 30 days of life in two-thirds of the patients, which is the standard criteria. So, approximately half of the pediatricians were facing a problem in getting the treatment and screening done for the ROP patients. So the main reason which came out to be the factor in these patients where they generally discharge the patient and then they ask the patient to get reviewed at ROP screening and treatment center. So why do they do that? Because they told they had an opinion that there is lack of adequately trained or most importantly interested ophthalmologists who are willing to go and screen at their centers. And so all of them, all the pediatricians were aware that ROP is a medical legal liability and it has the highest compensatory loss, which is equally divided between the pediatricians and the ophthalmologists. So how do they share this medical legal liability? So approximately half of the pediatricians told that they took written and informed consent stating that the baby refused screening when they parents refuse to get the ROP screening done in a small baby. So coming to the problem statement in type 1 ROP in Bihar. So this is from a tertiary care perspective of RIO. So none of the inborn patients developed type 1 ROP, and the mean gestational age was approximately 31 weeks, 3 days, and the mean birth weight was approximately 1300 grams. All the patients had history of oxygen supplementation, but the duration and the PO2 and the mode of administration was very difficult to ascertain because they lagged in the RBSK papers and the referrals from the district hospitals. So how was the spread of the type 1 ROP? So basically, most of the patients had stage 3 ROP at presentation, but the alarming presentation was that of aggressive ROP, which was present in 14 eyes in these patients. In fact, stage 5 and stage 4B patients also were considerable, which amounted to approximately 15 eyes in these both the stages. So coming to the aggressive ROP, so the mean birth weight was a little lighter among these patients, amounting to 1,000 grams, with a lower gestational age of around 30 weeks. And the PMA at which they required treatment was approximately 34 to 36 weeks. This was the earliest group to get treated. The main challenge while treating aggressive ROP is the need of long and robust follow-up after intravitreal injections, because it is very difficult to make the patient's attendant understand that they are going to need additional laser in these patients. So all the injections and laser are made free at RIO because it is covered under RBSK under special agreement with State Health Society. So approximately four patients needed laser alone, while laser with anti-VEGF was required in rest of the patients. Coming to stage 5 patients, out of 15 eyes that presented, 10 eyes got operated, and most of the patients had presentation at around 8 months. Stage 5 ROP even presented at 2 months of age. Probably these were the cases where the patient had aggressive ROP and the patient failed to get screened at appropriate timing. Coming to the stage 4A ROP, so approximately 34 of the patients got presented at 2 months of post-chronological age. And the mean birth weight was around 1200 grams, and the gestational age was approximately 29 weeks. And the treatment for which they came was around 40 weeks. So the main treatment modality was laser alone, and in patients, some of the patients needed PPV at further stages, and 4 of the patients got treated with PPV at the first presentation itself. Coming to stage 4B, so one eye had progressed from stage 4A to 4B despite laser. All the 7 eyes underwent vitrectomy, and earliest presentation of stage 4B patients were at 6 weeks. So coming to stage 3 ROP, 44 eyes presented with stage 3 ROP. Only 2 eyes underwent intravitreal anti-VEGF injection, followed by laser photocoagulation after 2 months. And other eyes, they underwent laser photocoagulation at 6 weeks of PCA. And none of these eyes, none of the treated eyes with laser progressed to stage 4 or stage 5 ROP. This is very important because this is the stage where we can prevent the blindness in these preterm babies. So to summarize, there is an increasing trend of AROP which we need to keep in mind. And there's a worrying trend of stage 4 and 5 ROP. So, very important is the satisfying anatomical and functional outcomes of treatment in stage 3 ROP. Most importantly, we need to have more trained ophthalmologists to screen in SNCUs at every district. So the ROP management is a multi-folk management. So united we stand and divided we fall is a very this is a principle which applies to ROP as well, where we can have a primary prevention, secondary prevention, and tertiary prevention at the level of the pediatrician, gynecologist, and the ophthalmologist. So these babies, they live to see, and let us all help them to achieve the beauty of light and life. Thank you. Next, I invite Dr. Satyaprakash Tiwari sir, who heads the Vitreoretina department and is the director of Drishtipunj Netralaya, and he is going to present on management of complex retinal detachment. So less than 30 weeks, they need to be screened at 2 to 3 weeks of age. And more than 30 weeks, less than 34 weeks, it is at 30 days of life. And the cutoff for the birth weight is 2,000 grams. This needs to be followed, and most of the times, the mother doesn't remember the LMP. So we need to look at the birth weight and any other risk factor for which the pediatrician says that the patient needs to be screened. Even at 36 weeks, the patient needs to be screened for ROP. So this is the criteria for, this is the current RBSK guidelines which is being followed. 30 to 34 weeks, 34 to 36 weeks, and less than 30 weeks, we need to screen early because they are going to have more chances of aggressive ROPs because they are going to be lighter babies.
Sir, is that for how long we are going to screen those babies? How long we are going to screen those babies? That is one.
So normal vascularization that is happening the retina is expected to grow temporarily at 40 weeks.
40 weeks, yes.
So we need to screen at least till 40 weeks. If the patient
that,
comes and if we are not sure that the 40 weeks the vascularization,
After 40 weeks?
so
is
if the
there any need
vascularization
for-
is complete,
Yeah.
we need not follow the patient. But if it is the first visit at 40 weeks, we need to have one more visit by the parents. And if the vascularization is not complete, it will depend on the stage at which we are seeing. So it is entirely on the stage. If we are seeing at 40 weeks and the vessels have progressed to zone 3, then we can follow up easily at 4 weeks interval. But if the vessel is still arrested at zone 2, we need to follow up early.
So that means if the vessels are at the equator fully grown up at 40, we need not...
Sir, it has to be fully vascularized till zone 3.
Till the zone 3.
Ora,
Yeah,
yes.
ora, till the ora.